traditionally, more than half of patients undergoing total hips or total knees receive suboptimal pain control because surgeons weren't very interested in that. That wasn't their job. Their job was to do the surgery and have the anesthesiologist take care of the pain. And then when they woke up in the recovery room, they said, go to the floor and have the nurses give them some morphine or Demerol. That was the pain regime. But this is all different now. Multimodal approach to post-op pain management as opposed to narcotic-based therapy is finding acceptance in a wider audience. Opioids, narcotics are bad. They're the potential drivers for side effects and poor outcomes. So the least amount of narcotics you can use or take will increase your options for a better post-operative result. And preoperative education, well, how are we going to do that? How are we going to get rid of the pain? So here we go. Multimodal pain combines oral and IVs. We started 2 days ahead of time. We put people around the clock on anti-inflammatories and acetaminophen, which is just Tylenol. And depending on your stomach or your history, that sort of thing, we can alter it. But you come in loaded, and Tylenol works centrally. Anti-inflammatories decrease the inflammatory mediators that are released when you have an incision. So we're sort of loaded to decrease the inflammatory response. All pain comes from inflammation. And when we cut your leg, your body thinks that it's been in the jungle historically like a caveman and you just got bit by a saber-toothed tiger. So man, your body just releases all these inflammatory mediators so you don't die from infection. But we're in a sterile operating room and the body genetically doesn't know that. So if we turn off all these inflammatory mediators, you won't get a lot of that pain. And this comes from the American Association of Anesthesiologists. They were smarter than us years ago. We just don't listen to them until it's too late. But for any surgery, they recommend now any anti-inflammatory that's safe for the patient, acetaminophen. Now they have intravenous Tylenol that we could give you in the hospital, or PO, and a neuroleptic, something like Lyrica or Neurontin that people take. So the American Society of Anesthesiologists recommends those 3 drugs on any patient coming into the hospital for surgery if there's no contraindication. And so that's important to ask your surgeon for whatever surgery you have. Some of those things may be contraindicated. The majority of them are not. The majority of those are not, and it decreases your pain response and your experience. So that's one of the multimodal pain aspects. So 2 days before you start that, when you come into the hospital, there's a host of IV medications now that the anesthesiologist gives you. Some, a little bit of steroids and antiemetics so you don't throw up. Another IV anti-inflammatory. This is all done preoperatively. And then whatever type of block you use, we use light general. Most of the time we use spinals. Now we got away from epidurals. Even the regional blocks we got away from. So, we sort of gravitated where we used to do blocks where we just numb up your leg. Well, what happened is people would fall all the time. So they couldn't get up because their leg was like a Gumby leg. So then you had to put them in a brace to prevent them from falling. And that would last, for 2 days. So that wasn't a good idea. So we don't want to stop the motor, we want to stop the sensation. So we figured out which blocks can stop that. So all this multimodal pain relief, and we go over that in the joint camp, is preoperative 2 days ahead of time when you come in. And then we do this periarticular joint block, which is this coolest thing that we figured out now. We could avoid the femoral block, the adductor blocks, and we put this long-acting new medicine that a lot of hospitals have an approved called Exparel, but it works really well because it can last up to 96 hours. So it's like going to the dentist and your mouth is down for 2 or 3 hours, which annoys you. It does not annoy you in the knee because once that wears off, it hurts. So it's kind of a cool thing to have and then be able to go home. So all of these multimodal pain modalities have allowed us to do rapid rehab. And remember, everybody gets this, whether you're in the hospital or not. So our people in the hospital are much happier than they used to be. And that's just a neural pathway that shows we hit it at every aspect of the pathway. We do the periarticular blocks where we do the incision. The Tylenol works up here. The anti-inflammatories work here. The neuroleptics work up higher, as opposed to the old days where the narcotics just worked on your brain. Here's the Exparel I was talking about. The cool part is that there is a component that starts right away. But look at this. It actually peaks at 48 hours. So This is when at 48 hours is when the peak relief is up here. And then it tapers down up to 96 hours. So we have to educate people, and they feel really good going home. They actually feel really good the next 2 days. They go, wow, I'm out of the woods. And then the third day, they go, wow, what happened? I kind of overdid it. But then they know it. So now we say, no, that's expected, so we don't have to handle 15 phone calls. It's how come, what's going on? Did they hurt me in therapy? And they open up their passport book, and we put them on round-the-clock anti-inflammatories and acetaminophen for a couple weeks afterwards. So we keep up this multimodal pain program for 4 or 5 weeks afterwards. So we've decreased the amount of narcotics. They still get a prescription for narcotics. It's not unusual for people to take none. So it's pretty cool. Narcotics are bad. They are cause constipation, depression, side effects. And then we go over how to avoid nausea, vomiting, urinary retention. If you're a male and you've had some problems urinating at night, benign prostatic hypertrophy, prostate problems, we talk to a urologist. If it's just frequency, we put you on Flomax. So you see the pattern here. We don't wait for symptoms to occur and your bladder to be full and you can't pee and we have to catheterize you. We sort of figure it out ahead of time. So this whole rapid approach is not treating symptoms when they happen. It's preventing symptoms from occurring. It's easier to avoid pain than to treat pain. And you need a care partner. We love this. And some people need help for a day or two, some for 2 weeks, depending on their age. And the other person has to understand the multimodal pain management, because if the patient's confused, they're laying down, they don't want to get their book out, somebody's there to say, now remember, here's what happens if you're a little sick to your stomach. And remember the old no eating or drinking after midnight? Like, think of all the things that we did that was crazy. We've stopped that. We don't want you to eat after midnight, but we want you to drink. So what was one of the bigger problems after surgery? You're hypotensive, your blood pressure's down, they have the IV, they're running in fluids. Well, it's because they're dehydrated. Not everybody gets operated on at 6 in the morning. Some are at 9, 10, 11, 12. They've gone 12, 18 hours without drinking. Now we want you to get up and drink in the morning. It's okay. And not every place does this or understands it. You can have black coffee without milk. You can have tea. You can have water. You can have Gatorade. You can have apple juice. You just can't have orange juice with pulp in it. But up to 2 hours ahead of time, we want you to come in loaded. Not loaded, you know what I mean? We want you to come in fluid loaded. We will load you. Anesthesia will load you. And hydration isn't just for your blood pressure. It lowers your risk of nausea and the need for blood. Let's see. I think we're doing pretty good. We go over all the DMEs ahead of time. We go over the ice or a polar care. Do you need crutches or a front wheeler? Do you need a raised toilet seat? What's your shower like at home? So this all happens in joint camp. Blood clot. Everybody used to be on rat poison, warfarin, Coumadin. It was crazy. We had huge bleeding problems. It took the orthopedic surgeons years to convince the medical groups that aspirin was okay. And now it's the standard of care if you don't have a predisposition to a blood clot. So we risk profile you from a clotting standpoint. The majority of people can get on twice-a-day aspirin for a couple weeks afterwards. But it's really not just the aspirin, it's really early motion. So it's getting up and moving. Remember the traditional hospital, you come in with your suitcase and your pajamas and your blanket and you're in bed. And so we did a big operation. The body wants to clot because we made it bleed and you're laying in bed like this for 2 days. Now, even if you're in the hospital with the rapid recovery program, you are up within 2 hours. You're walking around. You are less likely to get clots with that approach. So compressive boots, walking, early mobilization. And we don't stop aspirin or fish oil preoperatively. How many people had surgery go, stop your aspirin and fish oil? It's crazy, the things we've done in medicine. There's no contraindication for many surgeries, especially in orthopedics. If people aren't on a baby aspirin, I put them on a baby aspirin beforehand. Because we don't worry about bleeding so much, we worry about clotting. What does clotting do? It causes blood clots in your calf, pulmonary embolism. What's a heart attack? It's a clot in your heart. What is a stroke? It's a clot in your head. We don't like clotting. Patients don't like clotting. I start them on baby aspirin and fish oil, and they keep it up right to the day of surgery. And I work at a few other hospitals, and I just say, if people, if the anesthesia team says, we want you to stop your aspirin and fish oil ahead of time, I say, just shake your head, but don't do it. Because they really don't understand that. It's not a contraindication even to spinal surgery. And so, those are some of the things that we do. We are preloading your body to prevent abnormal clotting afterwards, just like for pain medicine. So it's a whole philosophy, it's a whole culture of doing this. And there's our, there's our prophylactic regime postoperatively. You come in hydrated, that prevents clotting. So we used to dehydrate you, and it makes your blood viscous, and it increases your risk of clotting. I have my own, approach, because I'm sort of a big believer in non-pharmaceutical nutraceuticals. And and patients say, well, they told me to stop my fish oil. I said, did they tell you to stop eating fish? They go, then you can have fish oil. And so we put everybody, don't stop your vitamin E, your omegas, your aspirin, your vitamin C. And there's and I tell people that this is an over-the-counter nattokinase. It's a Japanese nutraceutical made from soy that keeps your platelets slippery. Post-operatively, I put them on that. So these are all natural options instead of putting people on warfarin or Coumadin that don't need it. And a friend of mine, Steve Sinatra, wrote a great metabolic cardiology group. How many people 60 to 90 have a little bit of congestive heart failure? And these are 4 over-the-counter medications that I recommend any patient that has heart problems to go on. CoQ10 is depleted on statins. Half of the country is on statins, which is another pet peeve of mine. L-carnitine, D-ribose, and magnesium. You can go online and look up Steve Sinatra Awesome Foursome, and he'll give you the doses for your appropriate condition. But these are easy, cheap things that won't hurt you. They're good for your heart. They make it stronger. Did you know statins make your heart weaker? Because it decreases CoQ10. That's why people get muscle pain. It decreases CoQ10. And many people in my office are placed on statins from their docs, and they're not even placed on CoQ10, which is an important nutrient. So I could talk for hours on this sort of thing, but anybody's interested, there is a dark side of statins, and there's a whole bunch of books out there which are really, really good to read, made by lipid scientists that aren't paid for by the pharmaceutical companies. But if you don't like books but you like to look at videos, this is the 2 best videos. You could look it up online, called Statin Nation 1 and 2. It will go over the fallacy that cholesterol is bad for you. So that's another lecture for another night. Anyway, your skin has to be good. We don't want any open wounds. We don't want any diabetic ulcers. We go through a preoperative antibiotic shower ahead of time, and we go over all this sort of stuff in the joint camp. So it's all done. You go home with the dressing. You go home with a big Band-Aid that you leave on for 6 days, which is pretty cool, because you can shower and bathe the next day. You don't have to put it in that black trash bag and hold your leg out there. Wrap it in saran wrap, and really the wound is sealed after 24 hours, so you can get it wet, but this keeps it sealed for 6 days, and then it comes off. So every aspect of the surgery has been vetted by over 45 orthopedic surgeons in our method. Every step had to be vetted by what's called the Delphi method. Every step had to receive 70% consensus. If it didn't, it went back to the table, it was voted on, discussed again anonymously, and if it didn't hit the 70% consensus, then it wasn't voted on. That's the value of the Swift path. It's just not my ideas, it's 45 other orthopedic surgeons that vetted this. And you had 3 vetoes, so if you could veto anything, and that's why some of the medications never made it to the list, because they weren't passed by the Swift path team. So constipation, we don't like that. Nobody likes that. Again, hydration. Don't drink, so you sort of dry out. You get constipated. Narcotics constipate you. All of these things are designed to improve your experience. I can't tell you how many people, we've done surgery on, they did great. I'm in the hospital 2 days later, they have this tube down their nose, they've got an ileus, they're constipated, the knee or the hip is great, and they're absolutely miserable. There's nothing worse than an NG tube down your nose. So, historically, I don't think we did as good of a job as we could. Nausea, again, fluid, avoid the narcotics, small meals, urinary retention, we went over that. So post-operatively, This is where our pain is between 2 and 3 postoperatively with Exparel, the new long-acting Novocaine or Marcaine, versus the pain with the historical type. So we've really done a great job in decreasing that pain. And pain control is not just medications, it's cryotherapy, it's anti-inflammatories, acetaminophen, rest, and you do have narcotics, so we are not Attila the Hun. If it hurts, you know, you have some if you need it. Patient engagement is considered the blockbuster drug of the century. So motivated, educated patients are the most important drug of the century. And I'll tell you a cool thing that we found in those prospective study where we looked at patients in the hospital and patients sent home on the same multimodal pain. You know what we found in the pain surveys? No difference at all. No difference in anesthesia. The pain that they were put on beforehand in the hospital, the patients that went home reported 30% less pain. 30%. For whatever reason. We don't know. Is it the Hawthorne effect that they were being observed? It's that they went home and they expected not to have pain, but who cares? They have 30% less pain. And I sort of attribute it to the, you know, when you're sick and you're a kid and you have the flu and you're laying on the couch and you're in your pajamas, you have a thermometer in your mouth and you know you're getting chicken soup, you feel really sick. And after you milk that for 3 days, you know, then you put your clothes on and you get up and you go to Wawa's and you feel normal just putting your clothes on. It's the same sort of thing when people 2 hours after a knee replacement are in their clothes walking home, they just don't feel sick. They've had an outpatient procedure. They shouldn't feel sick. They shouldn't feel pain. And now they understand it. So it's sort of this cool thing that pain is this nebulous concept, but a lot of these things have alternative benefits. And so traditional length of stay is 3 to 4 days. In Swift Path protocol, our length of stay is 3/4 of a day. You know, our goal is to have 50% of our total joints in the next few years as an outpatient, smaller incision. We don't sacrifice alignment or results. We have no transfusions. You don't need blood in general by this approach, and a small percent of people need to go to skilled nursing facilities versus a third, and we've had 0% readmission to date using the strict protocol. So the whole paradigm has changed. The bell-shaped curve has shifted from 3 days inpatient rehab, skilled nursing, home health, lab, to less than a day using, you know, this program. So that was a really rapid-fire introduction to outpatient total joint arthroplasty, rapid recovery. And again, the take-home point is this led us down a pathway to treat patients better in the hospital. The majority of people still will be in a hospital, but the patient experience is unbelievable. We have nurses on the floor, and we sort of pride ourselves on just doing knees, and our patients, you know, in general in the hospital, the nurses say your patients always do pretty darn well, you know, compared to this group or that group. But once we started this, they said, I've been doing this for 25 years. What the heck are you doing different? This is a quantum leap in what we've experienced. The patients sleep at night. They have hardly any pain. There's minimal bleeding on their dressings. So this whole rapid recovery has changed our whole approach and philosophy. And it's going to be a major part of joint arthroplasty in the country going forward. And you know, we're proud to be on the cutting edge. I know you folks have a lot of barbecue food to go get at the grocery store, but I'll take questions for a little bit if you guys have any. Yes. So we do the same thing for bilateral knees, but our bilateral knees don't go home the same day. And so they'll stay in the hospital. But it's absolutely the same protocol, the same anesthesia. We just do it on both sides. They're up the same day walking. It's absolutely amazing. And I shake my head. I said, I've been doing this for decades. And I walk in the room to do rounds, and the patient isn't laying in bed like this, zonked on narcotics. They're sitting up, and there's a sign on the wall that they've just walked 100 feet. They're in their clothes, and they're in the room. They've had bilateral knee replacements 3 hours before. So yeah, everything's the same, except, you know, with bilaterals, you're in the hospital for 1 or 2 days. Yes? So we do PRP, yes. Yeah, I love PRP. Platelet-rich plasma is what she's talking about. It's It is, you take your blood, you spin it down, you take the red cells out, and you get this platelet-rich plasma, which has 1,500 growth cells, been in Europe forever. It's approved by the FDA in this country. You know, every NFL sports doc injects every injury with it. Being FDA approved and paid for by insurance are two different issues. So it's approved in Europe. It's wonderful for osteoarthritis, and there's prospective studies that show it's much better than probably, definitely better than hyaluronic acid and steroids in the long run. So it's good. It's paid for almost everything but arthritis. So for tennis elbow things and rotator cuff, it is paid for. Achilles tendonitis. You know, you never want to inject a Achilles tendon or a patellar tendon with steroids because you predispose it to rupture, but you can do it with PRP. So, but it's expensive, and I think the public gets sort of bilked by that sort of thing because, you know, the kits cost us about $300, so we pass it on to the patients. But you go to New York, they're charging $1,700 for an injection, and it's not a miracle, and it's not 100% predictable. I'm very sensitive to people's socioeconomic conditions, and really, there is a value to multiple injections. So on average, you know, my friend Jimmy Bradley, who takes care of the Steelers, and he operated on my shoulder, injected in my shoulder when he operated on it. But in his aging NFL players, he does it 3 times, a week or 2 apart, at 6 months and a year, and then once a year as a maintenance dose. And so really it's $1,000 investment up front. But I'll tell you, athletes will do it. They'll pay $1,000 for a nice new wheel on their bike, you know, but when they have to pay that for their knee. So, but yeah, and it won't help all meniscal tears either, you know, there's some that it won't. But yeah, it's a long answer to your question. Someone else said, yes? So in partial knee replacements, they're all preserved. In most total knees, the cruciate ligament is the only one that's removed. You know, some of the newer companies have come out with cruciate retaining knees, but I'll tell you, it's an absolute difficult procedure to do. Most people don't realize that 90% of all the knees done in the country are placed in the same manner. They're placed in a zero mechanical axis, so all the parts are cut 90 degrees to the ends of the bone, and you make somebody straight. Only 2% of the population is straight. 98% of the population has a little bow leg or a little knock-kneed. So most docs are not used to replacing the joint surface as it lies. So you can't retain the cruciate ligaments and make a 90-degree cut because that's not how 98% of the knees are. So there's a lot of gimmicks out there that companies came out with, and one of the companies that came out with it has the lowest market share, and there's no proof to date that retaining the cruciate ligament has better outcomes. That'll take 5 or 10 years. So there are all partial ligaments. You can't do a unicompartment arthroplasty without an ACL. It will fail. So you have to either replace it or retain it. So everybody that does unicompartments retains the ACL. One of the lower volume companies came out with a ACL retaining prosthesis, but I think it has 14% of the market share, and of that, less than 0.1% are doing it. So there's no long-term data yet to see if it's better or not. So all the proprioceptors are gone in the whole knee, because really the proprioceptors in the ACL are minimal, but the proprioceptors on the end of the bone are gone, which is why in a partial knee, it feels more like your normal knee because you have 2/3 of your proprioceptors there. But in a total knee, you know, it can feel you can never get arthritic pain again because you have no cartilage. But people will often say it's a great knee, I have no pain, my arthritic pain is gone, or I have less pain. But I could just tell it's not my normal knee because they lose their proprioception. Which is why, I mean, it's a real operation. I mean, it's easier to do it on people that are worse, when they come in and they are debilitated. But the people that come in their gym clothes and are, you know, working out 3 hours a day, and they have a little knee, and they say, it hurts a little bit, I want a knee replacement, so it's better. You know, you sort of say, well, you have to re-educate them. Yes? So today I used a rotating one. I use 6 different knees. It depends. It depends on the patient. You know, historically, the J&J LCS rotating platforms, they're a great, you know, there's no free lunch with any of these things. They have a good track record. They have a little more polyethylene wear because they get backside wear on the rotating polyethylene. So you buy a little bit of polyethylene particle wear. Most people in the country don't use rotating platforms. The majority of knees in this country are fixed bearing knees. They're good on revisions, and they're good if you have a kneecap tracking problem, because if you ride a bike and you have a fixed pedal, there's a pedal called the speed play where it's a round pedal and your foot finds its natural position. A rotating platform is the same sort of thing in the knee. So if you have kneecaps that dislocate or they track weird and you can't fix them, a rotating platform is a good option for that knee. So there's certain indications for certain knees. Yes? All the knees that we put in are designed to kneel on. It's a fallacy you can't kneel on. Because you can kneel on a knee doesn't mean it won't hurt. So you know, and I've got a little bit of kneecap arthritis. I wouldn't kneel on my knees. I'll kneel down after a patient and look at their knee, and I'll sit here and I'll be going, and then like, I go, why did I do that? And you know, it's really just physics. You're putting all your weight on a small surface area. So, but we do techniques to allow you to kneel. For some reason, women like to garden and clean their bathroom, but I can't find those women anymore, but there are. But they do, and so we don't put the incision right in the middle. We sort of skirt it off to the side, but you can kneel on these things. Yes? So there is an, you know, there's multiple variables that contribute to that. If you look in the literature, there's an incremental but not huge risk if you do both knees at the same time. And so that's our criteria to do them. But doing both knees at the same time has so many variables. Like I said, if you have a casual surgeon that takes 90 minutes to do a knee and preps and drapes the other one, you're in the operating room for 4 hours versus a dedicated team that literally can limit the surgical time to under an hour. That risk is lower on a bilateral than the casual surgeon that takes an hour and a half or 2 hours to do a single knee. So it's not just one variable. Good, great, thanks. Great audience, thank you.